Hello uh, to everyone, and welcome to this IMS webinar on perimenopausal contraception, a very important topic for our women. They are still in need of some contraceptive options. And today we have the pleasure to have two fantastic speakers to try to navigate this particular choice in perimenopausal women. I'm Professor Nappi from the University of Pavia, Italy, and we will start our webinar with Professor, I may say Andy, and Andrew Kaunitz. He is Associate Chairman of Obstetric and Gynecology and Professor in Florida, and serves as Medical Director at UF Southside Women's Specialist at Emerson. I know Professor Kaunitz since so many years, and what is really impressive is both the clinical expertise, the ability to produce tons of articles in peer-reviewed journal, including New England Journal of Medicine, JAMA, all the leading OBGYN journal on the topic of his favorite research, contraception and menopause. And he's also extremely powerful in explaining in very simple words what our field in women health work, video blogs for Medscape, OBGYN, Women's Health, and at the same time, he received so many distinguished service awards from ACOG and NAMS. So it's really fantastic to have him here. Second, she's a new friend because I didn't know personally before, but I'm so pleased to have Dr. Pelin Batur. She's Professor of OBGYN and Reproductive Biology at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. And also Dr. Pelin, she has a great clinical expertise, but she's also very, very active in many different areas of women's health, especially topics that are not always so well served, such as menstrual migraine, sexual concern after, for example, cancer treatment, organ transplant, in women carrying genetic condition or those they have increased risk. She has played a critical role in the creation of a variety of programs within the OBGYN department, especially the sexual health program, as well as the complex contraception clinic. So I'm practically sure you will really enjoy her ability to see this topic in a multi-dimensional, with a multi-dimensional view. She did also a lot of educational leadership position, and so I'm sure we will enjoy our webinar. And so we can move forward to next slide, because I have to remember to everybody that this webinar has been supported by an unrestricted educational grant from Bezens Healthcare, but Bezens had no role in the selection of topics or speakers, as not vetted or reviewed the content of the speakers' presentations. Please, Professor Kaunitz, the floor is yours.
So I'm honored to have been invited by IMS and Professor Nappi to make this presentation on the use of combination hormonal contraceptives in the setting of older reproductive age or perimenopausal women. I do have disclosures listed here. So my goal is that everyone participating in this webinar feel more comfortable providing guidance to older reproductive age women, helping them to make good decisions regarding the use of combined hormonal contraception, including pills, patches, and rings. In addition, I'll be describing appropriate ways to counsel older reproductive age women regarding termination of hormonal contraceptive use and possible transition to systemic menopausal hormone therapy. We're all aware that fertility declines as menopause approaches, but keep in mind that until menopause, sporadic ovulation, although less predictable and less frequent, sporadic ovulation continues until menopause. So a woman who's 40 has more than 80% chance of continuing to be ovulatory. A woman in her mid-40s, more than half of such women are no longer ovulatory. And by age 50, some 90% of women are no longer capable of conception. So why is this topic so important? Well, among women in their 40s who conceive, there's a very high abortion rate, which tells us that that women in this older reproductive age group are not, in general, not interested in becoming pregnant and would like to avoid it. In addition, when older reproductive age women conceive, the likelihood of adverse consequences due to comorbidities is much, much higher than in younger women. We'll discuss, starting with Centers for Disease Control guidance, we'll discuss evidence-based guidance regarding the use of combination contraception in older reproductive age women. I'd like to mention that this guidance is available on your Apple or Google devices. The app is free of charge. And if you were to Google contraception Centers for Disease Control, you'll find this app very readily, CDC contraception. And the CDC guidance uses 4 categories. The first 2 are listed in green because both of them indicate that use of the method is appropriate in that particular clinical situation. In contrast, Category 3 suggests that risks may outweigh benefits of using a particular method. And Category 4 indicates that the method should not be used in that particular clinical circumstance. An example of that might be use of combination estrogen-progestin contraceptives in women with a history of blood clot or pulmonary embolus. That would be a hard stop or Category 4. I'd also like to point out that the CDC guidance I'll discuss parallels very closely guidance from the American College of OBGYN, as well as guidance from North American Menopause Society, which recently changed its name to the Menopause Society. So all of this guidance, whether we're talking about CDC, ACOG, or menopause, the Menopause Society, the guidance is basically identical. In terms of age by itself, CDC indicates that healthy non-smoking women without specific cardiovascular risk factors can continue combination contraceptives until age 50 to 55. And in this setting, this would be a US MEC Category 2. However, we need to keep in mind that as women get older, the likelihood that comorbidities are present starts increasing rapidly. For instance, women who are obese, women who smoke, women with diabetes, hypertension, migraines with aura, or women with a history of venous thromboembolism. For all of these categories, which become more common in older reproductive age women, these would be US MEC categories 3 or 4, meaning that that these estrogen progestin contraceptives in general would not be appropriate. And in contrast, progestin-only methods, for instance, the intrauterine devices which release progestin, which we'll be hearing about shortly from Professor Batur, are more appropriate. So here are examples of progestin-only methods that are appropriate when combination methods are not appropriate, category 3 or 4. We know that the incidence of breast cancer starts increasing as women approach menopause. So an important question is, what impact does combination contraception have on a woman's risk for being diagnosed with breast cancer? Some of you may recall seeing in the New England Journal back in 2017 a Danish article that examined the risk of breast cancer with use of hormonal contraception using the Danish National Health Database and Pharmacy Database. The minimally elevated relative risk, again, 1.2, as you can see here, represents a modest elevation of risk. And given the potential for confounding, it's not clear to me that the results of the Danish study reflect cause and effect relationship. Keep in mind that well-conducted US and British studies that have used databases specifically designed to study this issue, unlike the Danish Health Database and Pharmacy Database, have not found that use of combination oral contraceptives are associated with an elevated risk of breast cancer. Whether there may be a small impact on risk of breast cancer or not, we need to recognize that all hormonal contraception represents a complex balance of birth control benefits as well as risks. Potential elevated risk of breast cancer should be balanced against the known benefits for each individual, and we should employ shared decision-making to help our patients make the decision that works best for them. I'd like to spend a few minutes now on non-contraceptive benefits that are particularly relevant for older reproductive age or perimenopausal women. In terms of perimenopausal symptoms, we do have data suggesting that combination oral contraceptives reduce vasomotor symptoms or hot flashes. We also know that use of oral contraceptives is very useful for women with irregular bleeding. Although we don't have data for patches and rings as we do for oral contraceptives, and this is because patches and rings have been available for much less time than oral contraceptives, it's likely that patches and rings bring the same benefits in terms of vasomotor symptoms and helping with irregular bleeding that we know oral contraceptives bring. We also know that hormonal contraceptives can effectively treat heavy menstrual bleeding and can allow many women in their 40s, for instance, who would otherwise be facing surgery such as endometrial ablation or hysterectomy, by using hormonal contraception, many of these older reproductive age women can avoid surgery. In addition, we know that use of combination pills reduces risk, substantially reduces risk of both endometrial cancer and ovarian cancer. Furthermore, when women, for instance, in their 20s and 30s use combination methods, we know that protection against ovarian and endometrial cancer persists for up to 4 decades after contraceptive use. I'd also like to point out that that combination methods offer risk reduction against ovarian cancer, not only in low-risk women, average-risk women, but also in high-risk women, including those with deleterious mutations in BRCA. And for women with BRCA mutations who have not been diagnosed with breast or ovarian cancer, use of combination methods, including oral contraceptives, represents standard of care guidance for these high-risk women until they're ready to have their risk-reducing surgery. What about fractures? Well, we know that as women get older, bone mineral density decreases. We also know that oral contraceptive use in older reproductive age women increases BMD. This is not true in younger women, for instance, in their teenage years or 20s, but in women in their 40s, use of oral contraception increases bone mass. In addition, a large Swedish case control study found that among women who used oral contraception in their 40s, there was substantial subsequent reduction in risk of hip fractures. So when older reproductive age women use combination contraceptives in their 40s, for instance, decades later, when hip fractures become more common, there is prevention associated with oral contraceptive use, and presumably this is true for patches and rings as well. Although a report from Women's Health Initiative observation study did not confirm such protection, importantly, the WHI study did not report results by age during which oral contraceptives were used. It's also clinically important to point out that for women who notice that their vasomotor symptoms or other perimenopausal symptoms increase during the hormone-free interval, I would recommend using oral contraceptive formulations with reduced hormone-free interval, such as 24/4 regimens or the old seasonique regimen with 3 months of pills in each pack. And there are seasonique style generic regimens available in the US and perhaps available in the countries where webinar participants are practicing. And these include 3 cycles of 3 weeks of hormonally active pills with estrogen, progestin, and 1 week of 1 week of ethinyl estradiol only tablets. So this would prevent vasomotor symptoms during hormone-free intervals, since there is no hormone-free interval with this type of approach. One can also prescribe continuous oral contraceptive use, either with specialized packing formulations which have only active tablets, or if women have older type 21/7 formulations, they can discard each pack after 3 weeks of use and start the next regimen, thereby using hormonally active pills continuously. Contraceptive rings can also be used either with a reduced hormone-free interval or continuously. A question that comes up a lot is, well, is gonadotrophin testing, specifically is FSH testing, useful for determining when women should stop using hormonal contraception? And the simple answer is no, it is not useful. If anything, it may be misleading. And so CDC, American College, OBGYN, as well as North American Menopause Society do not recommend FSH testing in this setting. Okay, so if we're not going to be using gonadotrophin testing, how long should healthy non-smoking women who are category 2 per CDC, how long should they continue to use combination contraceptives, pills, patches, and rings? Well, keep in mind that with the median age of menopause being about 52 years, half of non-smoking 52-year-old women are not yet menopausal. However, by the time women reach age 55, approximately 90% of such women will now be menopausal. So with these statistics in mind, I would suggest that women who are appropriate candidates in terms of medical eligibility criteria continue hormonal contraception, combination hormonal contraception, until they are in their mid-50s. Some women choosing to discontinue hormonal contraception in their mid-50s may wish to seamlessly transition to menopausal hormone therapy, and this can be accomplished without any hormone-free days. Women who have other means of contraception, for instance, if their partner has a vasectomy or they've had tubal sterilization, they can individualize with their clinician when to discontinue hormonal contraception and whether or not to start menopausal hormone therapy. So using the approaches I've outlined allows women to surf through perimenopause without any major ups and downs in terms of vasomotor symptoms or abnormal bleeding. So I hope that this information will allow all of those participating in this webinar to provide counsel to their patients so that their perimenopausal transition can be smoother. So in summary, women who use combination contraceptives who are lean, healthy, and non-smoking can use these pills, patches, and rings until menopause, taking advantage of effective birth control as well as the important non-contraceptive benefits I have detailed. And women who need contraception and choose to initiate menopausal hormone therapy at menopause can seamlessly transition without any hormone-free days in their mid-50s without the need for any FSH or other hormone testing. Thank you very much.
Okay, thank you. And I will now share my slides. Well, I wanted to just shift gears a little bit. One disclosure is that I have no conflicts of interest or financial disclosures. But another disclosure is, whereas Dr. Kaunitz's portion of the talk has a lot of evidence base, my portion of the talk has less evidence. And so I'm going to present that to you today. What I'm focusing on is a popular trend to use IUDs during the later perimenopause transition, progestin-containing IUDs, and add menopausal lower doses of hormones to actually help with symptoms. And this is where I'm going to present to you what the evidence is, and you can decide when you go back to your practice whether you feel comfortable with doing this approach. So just to take a step back, in the progestin-only IUD that started is all Mirena. It's hard to believe, is about turning 34. It was approved initially in Europe in 1990. And we didn't get this approved in the US until the year 2000. So we have lagged behind other parts of the world in terms of the use of IUDs, but it is increasing. So for example, When you look at 2015 data, 40% of the doctors in the United States, especially OBGYNs, were using the IUD for themselves, but amongst patients, it was only about 11%. And we did see some jumps throughout the world. For example, in Australia, they got some of the most increase in the demand for IUD insertions during the pandemic. And for us in the US, we also saw a big surge in the request, not only for birth control, but also for IUD appointments after our abortion laws became more restrictive. So across the world, IUDs are the second most commonly used contraceptive method after female sterilization. So it makes sense to incorporate this during the menopause transition. Why are we talking about this? So in your country, I'm not sure what search engine you prefer, but many people will quote Google things, right? And so when I go into Google, what Google is doing nowadays is instead of telling you here are a million different searches and you can start from page one and start reviewing for yourself, this AI, artificial intelligence, is generating a quick answer. And unfortunately, when it comes to contraception, I've found a lot of mistakes in this quick generated AI. So for example, if I say, can I use hormone therapy for perimenopause? It'll give you a very definite, very binary answer. Yes, you can use it to treat perimenopausal symptoms. And it seemingly is quoting, the Mayo Clinic, the National Health Service from England, so some reputable sources. So then I say, what type of hormone is safest? And it'll tell me that bioidentical hormones are safest. And it's seemingly quoting even what I've written for my hospital at the Cleveland Clinic, when in fact, that's not really what we say. AI is just trying to piece this information to give a quick summary. So this is what our patients are reading, that this trend of, instead of using combined hormonal contraceptives like Dr. Kaunitz talked about, is maybe using an IUD and a lower dose menopausal hormone therapy to help guide them through this. So because of the safety, because you're using lower doses, and also the novelty of this. For us in the US, I know in Europe, they've been doing this combination probably 5 years or so before us. For us in the US, this has become more of a trend in the last 5 years, but I think there is good data to support this approach. So when you look going back, this is an older pilot study, it was only 30 to 40 women, but this is interesting. This was individuals who were mean age 42, as young as 30s. They were clearly premenopausal. They had very low symptom burden. So even if they had only one symptom, and these were vague symptoms, bloating, headache, low mood, low energy, they offered them the 52 milligram higher dose IUD and transdermal lower dose estrogen. And women randomized to the estrogen arm significantly improved fatigue, hot flashes, even though they weren't terribly symptomatic to begin with. And we know that perimenopause is a window of vulnerability for mood changes for both depression and anxiety. And the updated guidelines do say that you can use estrogen for menopausal dose estrogen for this. So it seems like a good approach. And if this was a nice little study that was published, I think just only a few weeks ago, when you compare in the more menopausal age group, how do the risks of different hormones compare in terms of clotting? And this is really nice because it gives us the magnitude of risk for a lot of the risk factors for blood clotting we worry about. Metastatic cancer and recent hospitalization surgery, very high odds ratios, 8 to 13 times the risk for blood clotting. When you got into hypercoagulable conditions, it was a 3 times risk. But look at this, even a history of stroke or heart disease were relatively lower risks. And how did the hormones compare? When you looked at estrogen only menopausal doses, it was a very small risk. So number needed to harm to get a blood clot was over 4,200 patients. Versus if you use combined estrogen plus progestin menopausal hormone therapy, a little higher. But those individuals at these, again, this is an older age group, 50 and up, using combined hormonal contraceptives had more than 5 times the risk of blood clotting. So the conclusion from this study was that menopausal hormone therapy not only was a minor role in clotting risk, but it didn't seem to compound when it was combined with these other risk factors. On the other end, contraceptives were a stronger risk factor for blood clots. So this is a table I created taking both data that has published information on the daily doses of levonorgestrel secretion based on statistical modeling and also measurement. And most of the IUDs that we're going to talk about for this indication when we're using it in perimenopause is going to be with the higher dose, 52 milligram total IUDs. So as you know, this is the one that has more therapeutic effect for heavy bleeding. In the US, it's approved for birth control efficacy for 8 years, but we do have data that it can probably have birth control effectiveness for 10 years. However, for treating heavy menstrual bleeding, it's only approved for 5 years. We in the United States do not have an approval to use this with menopausal hormones, so that is an off-label indication for us. Now, I know in the UK that this is approved, Mirena brand is approved to be used with menopausal hormone therapy up through 4 years. So when you get into years after years 5, so initially it's deploying anywhere, between 2021 down to basically cutting to half the dosing per day. When it's at year 5, in the later years, we're going to get into 7 to 9 micrograms per day. When we're talking about the lower doses, that's really all they're deploying, somewhere between 7 to 9 or 5 to 6 for the lowest dose. You will see there's a little bit of a peak that's reported, but those higher numbers are really in the first few weeks, typically when you place the IUD. I will also show you some data of some of these more experimental ones that have been studied around the world. I am not aware that they are approved. They may be in your country. However, I will present some of the data of these as well. So let's take a step back. How much is enough progestin when you're using menopausal dose hormones to help these women? Because we know combined hormonal contraceptives are progestin dominant, so there's no issue there. That's why they reduce both ovarian cancer, but also uterine cancer so effectively. But that's not, you have to be careful when you're using menopausal dose progestins that you're using enough. So the best data that we have to prevent, in fact, uterine cancer is if you're using a progestin every day. Many studies show a reduction in uterine cancer use with postmenopausal dose progestogens. And let me take a step back. When I use the term progestogen, I'm talking about the big category of medicines that activate the progesterone receptor. So that could be micronized progesterone or a synthetic progestin. If I say progestin, I'm talking about the synthetic progestins. So progestogen is the big category, right? And the studies show that we shouldn't use, if we're using menopausal hormone therapy, we should not use any progestogen for less than 10 days, because that does increase the risk of uterine cancer. The British Menopause Society has a great guideline about the minimum recommended safe doses, whether you choose to use it on a daily basis or on a sequential basis. So cycling the patient with at least 12 days or more. I typically use 14 to 15 days when I cycle. And I just want to draw attention because across the world, including the US, it's become very popular to use micronized progesterone, which I think is a great product, but it is a relatively weaker progestin for some individuals, depending on their absorption. So if you're using this, for the 100 milligram dosing, the lower dose, you do want to use it daily. Versus if you're going to use it sequentially, you want to use it at least 12 days and at least the 200 milligram dosing. And one other category of individuals, for those individuals who have premature ovarian insufficiency, so what we used to term premature menopause, right? Menopause in their 20s, 30s, I typically go a little bit heavier with the progestins or the progesterones, because in those situations, we are using higher doses of estrogen. So patients where I need more progestogen are those individuals where there is a higher risk of endometrial cancer. And I do put the premature ovarian insufficiency in that category, not because they are higher risk of endometrial cancer, but because oftentimes we are using estrogen dosing to help with their symptoms that is in the we're trying to get to reproductive physiologic dosing, and we don't have long-term data for how much progestin is enough. And, in the US, we have a growing rates of endometrial cancer, so I do want to make sure that I'm giving enough progestogen. Luckily, if you're using an IUD, that is one of the most effective ways to give the progestin to the uterus. So we know for heavy menstrual bleeding, it's more effective than oral treatment. We often use it to treat endometrial hyperplasia in the United States. That is an off-label use. In patients taking tamoxifen, we use it to decrease a chance of endometrial polyps or endometrial hyperplasia. There's no proof that it prevents endometrial cancer in this population, but it's hard to prove that you're going to reduce endometrial cancer when there's a more rare side effect. So we use hyperplasia as a surrogate. So as I mentioned, endometrial protection with estrogen is off-label use for us in the US and Canada. But I'm going to go through meta-analyses that show that it is better than estrogen than systemic progestins by mouth when you're using it to prevent hyperplasia. And in the UK, it is approved for this purpose. The data is good, they say, through 4 years, and they recommend protection up to 5 years and changing it at 5 years for the UK. So when we think about endometrial hyperplasia being treated with levonorgestrel 52 milligram IUDs, what are some of the advantages for it? Well, these advantages for using it for endometrial hyperplasia are some of the same advantages for perimenopausal individuals. So we do know it works better because it has higher regression rates, lower relapse rates, and it can be offered to those with other contraindications to progestins or people who don't tolerate progestins, offers long-acting contraception. As Dr. Kaunitz told us, it's still important for the perimenopausal women, don't require daily dosing, all advantages in the perimenopausal groups. And so the nice thing is we do have meta-analyses of randomized controlled trials that show that there's no difference in irregular bleeding between IUD and oral. And in fact, many studies show that the IUDs do a better job. How about the lower dose IUDs? So most of us are going to be using 52 milligram, the higher dose for this indication. But the lower dose IUDs are all associated with marked progestin effect on the endometrium. Okay. But these are studied in those who are still having reproductive levels of estrogen. So let's look at some of the science. This is a meta-analysis. So it brings together all the randomized control studies. It's a little bit older study, but it has really good data. So most of the patients in this group were either perimenopausal or postmenopausal, and they were given estradiol valerate. For us in the US, we only have that available in one birth control pill form, or 50 microgram patches, a very commonly used formulation across the world. And what they found is that for those who were using the IUD, there was no proliferation on endometrial biopsy in any of the patients. In contrast, those who were using medroxyprogesterone acetate, about just close to a half had proliferative endometrium. And when I'm talking about, especially a postmenopause, like a woman almost in postmenopause, I don't consider proliferative endometrium normal. Really, when you're getting into low estrogen states, it should be, we're hoping for a more secretory or a more progestin dominant endometrium to prevent bleeding and to prevent cancer. So the overall summary of these randomized controlled studies is that you're going to get more consistent endometrial atrophy with the IUD as opposed to the progestin, like an oral progestin. Typically, patients are going to experience more spotting or bleeding in the first 3 to 6 months. All studies consistently show this, but typically you're going to have less bleeding after a year with the IUD. And the good news is, in terms of lipid profile, menopausal symptoms, there were no major differences seen between the IUD users or the systemic progestin users. But as you would predict, there was less discontinuation with the levonorgestrel IUD because it's, we know in general for contraception, this IUD has the highest continuation rate. If we expand our search and look at the data, including prospective studies, you get a few more studies, including some of the phase 2 and 3 trials that were done by mostly by Bayer. And the summary for that science is that you are getting study durations that are typically short. There's very few that go beyond 2 years for endometrial safety. Most of these studies have less than 100 patients, but they are using a variety of the estrogens that we typically use in this population. And studies show good symptom control, good rates of amenorrhea for both perimenopausal and postmenopausal women. Again, with bleeding being most common in the first 3 to 6 months. The one caveat here is that most of these individuals that are being looked at are in their 40s and 50s. So when you get into potentially wanting to use IUDs for endometrial protection in individuals over 60, then as the uterine cavity starts to get smaller, I do worry about the tolerability, and we don't have a lot of good science for those patients. And this is what I call an oldie but goodie. So an old study, but it really showed important points here. This was, I believe, out of Finland. And what they did is they used a 1.5 milligram estradiol percutaneous gel, and they randomized patients to have the IUD or what they call a natural progesterone, which is the micronized progesterone, either orally, 100 milligrams, or vaginally. I will draw your attention to the fact that it was only for days 1 through 25 of the month. And remember, we talked about really this should be 100 milligram daily to optimize protection. So when they did endometrial assessments at baseline at a year, they looked at ultrasounds, and there was a little bump in the ultrasound for the progesterone users, but very small, about 5 millimeters as a group. Levonorgestrel IUDs induced atrophic changes of the endometrium on biopsy in all of the patients, but most of the patients doing the oral or vaginal progesterone showed proliferative features. And just as a reminder, especially in postmenopausal women, I don't consider proliferative changes a normal or benign finding. It's a cue to me that either they need more progestin or progestogen, or that they need to decrease the estrogen dose. So that's the main points, takeaways, I think, from this, is to make sure that your progesterone dosing is always matching the estrogen. You always want to use at least 100 to 200 of natural progesterone if you're going to use that. And IUD is going to be a better way to suppress the endometrium. So how about the lower dose IUDs, or using the IUD beyond 5 years? So where we're deploying essentially something within the 5 to 10 microgram per day range. So I just want to highlight again this table. So I'm going to present to you some data coming out of Belgium here, just so you can orient yourself. So these are smaller studies and fewer studies. Just to highlight, this is the 14 microgram levonorgestrel IUD that I don't have available. So I'd love to see in the chat if your country has IUDs that are approved for use to protect the endometrium, to oppose the estrogen with menopausal hormone therapy. Please jot down your country if it has a formal indication. And also, if you do have some of these lower dose IUDs that are like this Fibriplant and Femolis, if these are actually approved in your country, I would love to hear about it in the chat. So the 14 microgram Fibriplant that was investigational. They used it for 3 years in both perimenopausal and postmenopausal women. And at this dose, 14 micrograms a day, no hyperplasia. Most of the patients did have an atrophic endometrium. Only 2/3 of the patients, though, did go through biopsy in this. This is another study, again, using a different brand, an investigational IUD, 14 micrograms. These individuals were actually followed 5 years. They replaced the IUD at 3 years. This is a little bit of an older group on average, and again, mostly atrophic, but there was weak proliferation in 2 women. How low can we go with the IUD? So this is a study, again, this was an investigational IUD. I'm not sure that it's ever been approved, but they went down to 10 micrograms and they compared it to our higher dose, like the Mirena type of IUD, 20 microgram, versus the oral medroxyprogesterone acetate. And they looked at endometrial biopsies, baseline, 6 months, a year. Good news, no hyperplasia in any of them. If you did the lower dose IUD, most got strong endometrial suppression. With the 20 microgram higher dosing, everybody got endometrial suppression, but the medroxyprogesterone acetate users, half of them were proliferative. This is the study I showed you before. And they've actually even done studies going down to 5 microgram IUD. And when you get so low, you do start to have some women discontinuing it because of bleeding. However, if they didn't bleed, most of the endometrial biopsies were non-proliferative. So it seems that we can go low, but I do want to highlight that for contraceptive mechanisms of an IUD, there are multiple backup mechanisms. That's why they are so effective. But when we're talking about a therapeutic mechanism, we really are relying on getting enough progesterone or progestogen to the uterus. So we can't say, okay, this IUD is approved for 8 years for contraception, so it should be good to use for 8 years to protect the uterus if I'm giving extra estrogen. So we don't know the optimal release of for levonorgestrel for therapeutic effect. And so if I summarize some of this data, it suggests to me that doses as low as 3 to 5 micrograms per day is capable of endometrial suppression, but not necessarily if you're using extra estrogen. 5 to 7 micrograms per day may counteract low dose estrogen, but I'm not sure I would trust it with my patients. But 20 microgram per day with the higher dose IUDs that gives you great endometrial protection, probably better than what you can with a oral progestin. However, we know that for therapeutic effect, for adenomyosis, large polyps, sometimes even that's not enough. So we really want to separate the therapeutic and contraceptive indications. And then it would be great if we had studies that could correlate levonorgestrel levels in the serum to what's happening with the bleeding and what's happening at the level of the endometrium. But unfortunately, we don't have that. There's just too many variables. Sex hormone binding globulin, levonorgestrel serum concentrations vary. However, for the estrogen, we may be able to use this. So remember, most IUD studies are in premenopausal individuals. So they have higher levels of estrogen, and menopausal hormone estradiols are typically producing 80 picogram or lesser. So my last 2 slides here for key take-home points. The 52 milligram, the higher dose IUD that provides 20 micrograms per day to start, is very effective for endometrial protection if you're going to use basically menopausal lower doses of hormone therapy. And I do want to put a personal opinion in here, especially leading the sexual health program, seeing a lot of vulvodynia. There are some individuals that just do better with the postmenopausal hormones. For example, they may hot flash still on a 20 microgram pill, but you switch them to this regimen, and because their body was looking for estradiol, not ethinyl estradiol, and they feel better. So some individuals will feel better even though the doses are lower. And most of the safety data, keep in mind the caveat, is going out really 2 to 3 years. Approved up to 5 years in some countries. I'd love to see in the chat which countries for endometrial protection. And keep in mind that Dr. Kaunitz mentioned, the ovarian cancer prevention, for example, in the high-risk patients. Just know that we don't have data for endometrial protection in our highest risk patients. So the hereditary non-polyposis colorectal cancer, also called Lynch syndrome, or high BMIs. These are patients typically not studied. So we have good data to use lower dose IUDs, but I'm not sure we have enough data yet. And always consider the patient in front of you, their BMI, their endometrial risk factors. So what do? I feel very confident that I have great data for at least 2 years. So I feel comfortable with the data for use for 4 to 5 years if I'm using a higher dose IUD. Beyond that, I'm usually adding a progestogen. And I always when I look at published studies, I always look at benign proliferative findings with, caution. And I love not worrying about bleeding during the perimenopausal time, but I also worry about if they have a lower dose IUD, if they do bleed, how I would evaluate it. And that is what I have. And I will stop sharing here.
Thank you very, very much. As I told you at the beginning, dear friends, our speaker, they put together very good science with clinical experience. And so I want to take all the questions from the chat. So brief answer, but we try to accommodate everybody. I would like to start with a dear friend of mine, Anne McGregor from the UK. I know her, and she's writing to us, why do we continue to recommend hormone-free interval for our patient? And also, she's curious to know something more, in your opinion, about the use of newer combined pill containing natural estrogen versus ethinyl estradiol for these categories of women. I think, Andy, you can take this.
Well, hello, Dr. McGregor. It's great to have you on this webinar. You and I are in sync. I don't think there's any reason that perimenopausal women should have any hormone-free intervals if we're prescribing hormone therapy to them, whether that be a pill or a vaginal ring. And I hope the strategies I included in my slides to eliminate hormone-free intervals are helpful, because you and I are in agreement. You are a headache specialist, and you are particularly sensitive to risk of headaches associated with hormone-free intervals. So I'm glad you brought that up. Thank you.
Although I will say, some patients do prefer to have more predictable bleeding if they have. So I agree with you. I typically offer continuous, but if they are really plagued with a lot of bleeding and they're constantly coming back for evaluation, sometimes they will prefer, as long as there's no symptoms that are worsened, and like with headaches, PMS. And of course, if I'm really worried about bone health, there are studies that show continuous use is better than cyclical use for bone health.
Same line, we have another question, and maybe we can go more deeply into this discussion. Estradiol valeriate, for example, against ethinyl estradiol is the topic from Anna. And there is another question regarding, for example, the use of estradiol in this category of women from OD from Belgium. Andy, start yourself, and then maybe Pelin will comment also.
Well, Dr. Batur alluded briefly to the fact that 17-beta estradiol may have different therapeutic effects compared with ethinyl estradiol. Ethinyl estradiol is a highly potent synthetic estrogen that is clearly associated with an elevated risk of thromboembolism. We only have one non-ethinyl estradiol pill in the US. That's the estradiol valerate combined with Dienogest, which is called, I think it's called, was it Natasha?
Natasia.
Natasia here, and what's it called, Dr. Napi, in Europe?
Clyra. We have Clyra, that is estradiol valerate, Dienogest, the same as Natasia, And then in Europe, as you know, we have Zoeli, that is a combination of 1.5 estradiol plus normegestrol acetate. And nowadays we have also Drovelis, that is a combination of estrator with drospirenol.
Well, if I had my preference, none of the birth control pills I would prescribe would have ethinyl estradiol, but for pricing reasons and patient financial reasons, it ends up that pretty much all of the pills I prescribe have ethinyl estradiol because they are so much less expensive. But I agree with the person asking the question. I think estradiol and E4 estetrol are safer from the perspective of thromboembolism risk. And I hope going in the future, more and more of my patients will have access to these newer combination pills rather than the older and I believe less safe or more dangerous ethinyl estradiol.
Yeah, this is very good comment. And, we have real world data for both estradiol and estradiol valerate. We still are awaiting the real world data on thromboembolism for estradiol, but they are very good biological. It's biologically plausible that is less thrombogenic. And now another point that I think is for Pelin, and it's which route of progesterone administration would you choose when you wanna produce a combined menopausal hormone therapy with estrogen? So you prefer the oral or you prefer the intravaginal for micronized progesterone? What's your experience? Do you have specific patient in which you do one way or another?
I only switch to vaginal micronized progesterone if there's a tolerability issue, because I think for most patients, they don't want to put something inside the vagina every day. And also, we have more data with oral use. But we do know, just not for the synthetic progestins, but for micronized progesterone, how people metabolize it makes a difference. So when you take it orally for individuals, it can have a sedating effect, which is great for all the patients that are waking up with hot flashes at night or having sleep disturbances. It activates, when you take it orally, it activates the GABA receptors, so it can have an anti-anxiety effect. So if I'm going for those goals, definitely oral. But for some individuals, it's just far too sedating and they don't tolerate, which is when I switch over to vaginal.
Same line, Pelin. Always an anonymous writer say, can we give a micronized progesterone in a breast cancer survivor receiving tamoxifen? So meaning that you believe that this is better for the breast and at the same time you protect from hyperplasia. Do we have any data out there?
So in breast cancer survivors, if it's if it's hormone receptor positive, most clinicians in the US are not using hormone replacement in that situation. It's always negotiation, even just to be able to use a levonorgestrel IUD. So it's really a personalized decision between the patient, the gynecologist, and the oncologist, a primary care doctor. So in those situations, no, I'm not using. And to be honest, we know the E3N data, I believe, showed that micronized progesterone did not have breast effects like the other synthetic progestins did. But there was recently, just a few months ago, a great study published in Menopause that looked at US Medicare, over 10 million Medicare patients and the whole point of it was to look at hormone therapy users in their 60s and beyond versus non-users or those who discontinued. And in that study, micronized progesterone did have a bump up in the breast cancer risk, in contradiction to the French data. So I'm not really convinced that it brings the breast risk down to zero.
Yeah, I agree. It's an ongoing discussion, by the way. There is another question. I think this one you can take, Andy. How How late can you start combination combined contraceptives in a healthy, normal BMI perimenopausal woman? Do you propose also to women over 45 and 50? And which one are your favorite product according to the age?
Okay, so the question, as I'm understanding it, Professor Nappi, is it okay for an older reproductive age woman to initiate combination contraception? And yeah, and the answer is yes, as long as she is a healthy, lean, normal BMI, non-smoking woman. Um, um, and I would start any combination method, but I would probably have a bias towards 20 microgram, or if my patient has access to a non-ethinyl estradiol method, pill, I would also prefer that, like the E4 or the estradiol valerate, both of which are available in the US, but unfortunately much more expensive than the ethinyl estradiol pills. So yes, it's fine to initiate hormonal combination contraception in that older reproductive age women. Usually when I do, it's in the setting of perimenopausal symptoms, women who are bothered by vasomotor symptoms, women who are bothered by abnormal bleeding. But I also have a preference, like Dr. Batur, I have a preference for IUD plus transdermal estrogen in that setting. So I might start a combination contraceptive in the setting of the symptomatic perimenopausal women, but if the patient is interested in IUD placement and using transdermal estradiol, that would probably be my favorite approach to this patient.
Thank you, Andy. We have learned that Mirena is approved for endometrial protection for 4 years in Hong Kong and for 4 years in the UK, but people in Europe, they usually use up to 5 years. And there is an interesting question of somebody saying that in my country, unfortunately, levonorgestrel IUD is not readily available due to the cost. And so he or she they're asking, what about a tonogestrel implant for protection of the endometrium, or even intramuscularly MPA or NITA? Do you have any experience about that?
Yeah, so the etonogestrel implant is a good idea because it also leaves some of the estrogen around for the patient. So you can always add additional estrogen on top, but patients typically still, it's not like the intramuscular Depo-Provera shot where you really get low estrogen levels. However, the bleeding, when you start adding estrogen, a lot of patients are plagued with a lot of bleeding in my experience. But I think if a patient does well, it's a viable option. Dr. Kaunitz, do you have? Oh, you're muted.
Unfortunately, we don't have data regarding endometrial protection with implant. I wish we did. There likely is some endometrial protection, but we don't know. And so I agree with you, Dr. Batur. I wouldn't use the implant for endometrial protection. Depo-Provera and northisterone or northindrome injections are both high dose progestin injections. They will provide endometrial safety, but they may have a side effect profile in some women, including mood changes, bloating, increased appetite that might make them not appealing for some women, but they can be used for endometrial protection with estrogen use.
And one other comment about that, norethindrone or northestrone acetate at 5 milligrams is such a fascinating molecule, right? Because it does have some conversion into ethinyl estradiol.
Yes.
So that's actually, that's oftentimes a cheap and effective way if you want them to get a little bit of estrogen, but also get good endometrial protection and amenorrhea. That can be tried. But if I'm ever using 5 milligrams or higher of norethindrone, northistrone acetate, I will oftentimes back off on whatever estrogen I am providing because I know there's going to be some estrogenic effect from the metabolism.
You're right. We use a lot of label according to some study from Italian researcher Nita for the treatment of endometriosis, because you provide at the same time progestogen, a strong effect, and a little bit of estrogen without exaggerating. I think we have room for the last question. And I select this one because it's interesting and I think you both can answer. Can ladies with Lynch syndrome have hormone replacement therapy safely after risk reduction surgery, or is it better to counsel that you should not take any hormone treatment?
I'm going to let Dr. Batur, because she runs a clinical service for cancer survivors, and I believe likely sees many more Lynch syndrome patients than I do. I do see BRCA patients, and we discussed that, but I think Dr. Batur has more experience for this question.
Yeah, so I do like to keep things progestin dominant in those situations to make sure that they're not being plagued with bleeding, because any cancer survivor that's going to have bleeding, they're going to be worried, right? And they're going to need a lot of procedures. But also, if you keep things progestin dominant, you're going to get endometrial cancer protection. So I do follow the British Menopause Society guidelines that I quoted there for you. That's referenced in the slide. So that's my minimum starting point, because that's the guidelines, that's the minimum starting point for strong data for endometrial protection. Or to use, if you use a birth control pill, then in that situation, you are getting strong endometrial protection.
Thank you very, very much. And if I may, I would like really to thank our guest speaker today because it was very, very informative. And if I may show the final slide to thank everybody for being part of this educational activity, I would like to thank also the Educational Committee of the International Menopause Society for selecting the topic and the speaker. And from this cartoon, you can see how many things are going on in our fantastic International Menopause Society. Please go to our website to discover more exclusive offer for IMS members. So become a member of the society. Free 1 year IMS membership if you complete an educational program on the menopause, the Impact Level 1. And IMS offers a lot to local and regional society who become members of the Council of the Menopausal Society around the world. And we have all these monthly live events and extensive library of educational resources. And it's extremely important also to remember to everybody, the next slide, please, that we wait you all at the 19th World Congress on Menopause in Melbourne at 1922 October this year. And with this, I thank you very, very much for being here today. And we go back to work, and you may listen to this activity on our website again, or you may share with some colleagues if you enjoy. Thanks, Andy. Thanks, Pelin. And thank you for everybody. Have a nice rest of the day. Ciao, ciao.